Hello, everyone. Welcome to a special edition of our Grand Rounds. Today, we have a special time and a very special guest with us, Dr. Valentin Fuster. Dr. Valentin Fuster gave us Grand Rounds before on the imaginomics on subclinical atherosclerosis. And if you missed that, you can find that in YouTube. He needs no further introduction, but he's the physician-in-chief of the Mount Sinai Hospital, editor-in-chief of JACC, the main journal for cardiology, and he's the director of Mount Sinai Heart. He recently also got an award named after him at the ACC, and he was the first recipient, and he has a long career on imaginomics and plaque and atherosclerosis. The idea today is that we will have a Q&A, so please put all your questions in the Q&A box and we'll go through them. And we'll have our fellows also have some questions prepared for him. So thank you for being here, Dr. Fuster, and it's an honor to have early coffee with you, not something I get to do every Monday.
Sure. Thank you.
Okay, so it was a great lecture. We enjoyed it last time. I think as an opening question would be, who do we image for subclinical atherosclerosis?
Well, first of all, first is to know the technology that we use, and that is, this is non-invasive technology, which is 2D and 3D ultrasound, addressing the carotids, the aorta, the iliofemoral region. And the technology is going to be very automatized very soon, in which it will be possible to quantify easily the cubic millimeters of disease in the main arteries. And then at this moment, one can learn to do the 2D and 3D at these segments, but I think it's going to be very soon automatized. And at the same time, the coronary arteries, we cannot go directly, non-invasively, except for calcification, which is an indirect approach to address the coronary arteries. So I think the question about who is going to be imaged, I can guarantee to you that in the future, everybody will be imaged, and starting at a young age. And it's not going to be an expensive technology. And I think the way that we'll start is imaging only the iliofemoral region, which is where the disease most of the time begins. So I think that the integration of risk factors and getting into the iliofemoral region to start with, which is in 75% of people where the disease begins, is going to be the takeoff. And if I can predict, I don't know, in 5 years, maybe 10 years, people from age 20 on will be imaged. And my prediction is that will be the integration of, again, of risk factors and imaging. The great advantage of imaging is that it tells you who develops the disease. Risk factors is a statistical game. 50% of the smokers will develop disease, 50% do not. If I see the disease with the imaging, you already know you are dealing with the highest risk individuals. So I think this is going to be the way, at least that I predict in the next 5-10 years.
Okay, that's very good. And what are we looking when we screen? Are we looking for high-risk plaque? Are we looking for plaque?
No. Let me tell you, the concept of vulnerable plaque and high-risk plaque is a concept of autopsy. And actually, I think we were part of the development of the concept, but this was all autopsy. With Michael Davis, Eileen Falk, and myself, we actually worked together. And that is, you had a patient with a heart attack, and then you saw that was a plaque that was very rich in fat. It was a plaque with a very small barrier between the blood and the plaque, which is the cap. And then this plaque ruptures, and you say the vulnerable plaque. I would say the great flaw in the concept is people now go prospectively and say, I'm going to identify the vulnerable plaque, when in fact there are so many. So the concept is, if you say, I'm going to identify the vulnerable plaque that will lead to a heart attack, I think you are dreaming, because there are many plaques like this. So this is the change from autopsy to a prospective approach is really not feasible. So I think that what is feasible is the burden of disease, and that is how much atherosclerotic disease you see subclinical has an impact. And we already finished the study, which is going to be published very soon, is the bioimage study. This is a study in people, 6,000 people in the Chicago and in the Florida area, that they were imaged, only the carotids, however, and the calcification of the coronaries 12 years before, and we followed these people for 12 years. And we found unequivocally is the burden of disease, the quantity of disease was predictive of mortality. This is the first time that this is done longitudinally. So I don't care whether the plaques are fatty or not, or all of that, except that we are learning a lot with positron emission tomography and MRI to how the plaques progress from one type to another. But when your question was more of a question, how we apply this to the public. I don't think the qualification of the plaque, what type of plaque is going to make much difference. It's going to be the burden. So I think you have to distinguish all these things.
That's great.
Morning, Valentin.
Hi, how are you?
Good. I'm here surrounded by 3 smart fellows. They compensate for my deficiencies here.
Well, you are the fourth fellow. This is smart. You are number 4.
But I have one person here that I want to comment, and I'm going to deviate from the agenda here. On my left, I have Jay Chudo, who's going to join our faculty here. And I tell you what Jay had done, which was recently profiled in NPR. He looked at the prevalence of new episodes of atrial fibrillation that occurred following the daytime savings, the daylight time savings. So every time the clock switches, there's a spike in the events of atrial fibrillation, and we'll be able to prove that from our database here. And I think that comes to the issue of why it's so difficult to predict who's going to have an acute coronary syndrome, is because there are factors that are internal and there are factors that are external. And I wonder what do you want to what do you think about that?
Well, first of all, my comment is that is absolutely correct. I mean, you can predict certain things, or you can explain certain factors, like atrial fibrillation 4 hours after alcohol intake. You can predict atrial fibrillation in 25% of people undergoing cardiac surgery in the first 2, 3, 4 days. And you can predict atrial fibrillation, in a number of situations, stress and so forth. So this same applies to coronary artery disease. I think the timing depends from so many things. But I am curious about your explanation about the change in hour making a difference in the incidence of atrial fibrillation. How do you explain this? Is because people are sleeping less?
That's the question. There's a thought that people are sleeping differently, not necessarily less, but not as deeply, not as good sleep. And then there's also people do lots of things to help them sleep, whether drinking more alcohol, taking medications, other things like that. And then there's also just the change in time, the amount of natural light that's out there, and that our circadian rhythm and body's rhythm is often some way similar to, very similarly to jet lag. And we know certain arrhythmias happen with jet lag.
Have you found these change in hour recently? We slept less, 1 hour less. Have you found the same thing when we sleep 1 hour more?
So most from our data, as well as others around the world who have looked at heart attack, strokes, and such like that, the spring transition where we sleep 1 hour less, it seems to be much happen there. It's shown to happen there, whereas in the autumn change, it's not as frequently seen.
But you still have data that when you sleep 1 hour more, there is some trend on the same thing?
Not from our data set, but from others, they have published that, yes.
Yeah, well, Anyway, there are points of view, but I think, you know, there is a study just published, actually, you probably are aware, the more hours you sleep, less atrial fibrillation. And the study was just published. I think it was in the European Heart Journal, if I am correct. And so there's a relationship between the sleeping time of hours and the atrial fibrillation, no question about it. So anyway, thank you very much. It's interesting, but it tells us how much factors that we don't dominate play a role. Yeah, I agree with you.
And Dr. Fatou, one of our fellows, Mike Fatou, had a question about what we do with these findings. Mike, do you want to unmute yourself?
Hey, Dr. Fuster, thank you so much for joining us today. So my question is actually related to plaque characteristics. So I guess, are there patients that you think we can use plaque characteristics to sort of guide our management, whether that be guiding medical therapy or even selection for PCI, you know, depending on the amount of calcium, depending on the attenuation or the cap characteristics, or do you think it's a bit too far down the line?
Well, this is nice to talk. It's not going to work, in my view. Again, medicine moves simplistically. If you really go to the history of publications, of details, at the very end, we do something very simple. And so I think that to reach the stage of personalized medicine depends on the type of the plaque will do X, Y, or Z. I just don't believe it. I don't believe, I think academically is of interest and gives us the sense of new concepts. I think that in that aspect, I feel very positive. But the application of complexity in patients, for example, looking at different types of plaques and different timings, frankly, I don't think it's going to work. And one example that came out from my friend Greg Stone, who's with us here, and that is sure, you can go to soft plaques after an MI in the arteries that do not have the culprit lesion, get those little obstructions with fat and do an angioplasty, or put a stent and you will prevent plaque rupture. Well, I have two problems with my friend Stone. The first problem is there are so many plaques that are not obstructive in patients who develop a myocardial infarction. Remember, these are patients that manifest already the disease. These people in general have 2 or 3 vessel disease elsewhere with plaques that are not very stenotic. Are you going to put 7 stents on people and see what happens? I think you're going to develop a new disease, but then comes the data, and the data says there is a decrease in events from 7% to 1%. Well, these were not events. These were patients who require more medicine because of angina. And once you have these angina events in pharmacological, you are very worried about what is real, what is not. These are not heart attacks. And these are not, you understand it. So I think the study is fascinating in saying, yes, you can smash a plaque that is 30% obstructive with a high content of fat. But doing that, if you're going to go into that route, I can tell you the patients may end up, people who never had a problem, may end up with 4 or 5 stents. And do you think this is good news? I don't think it is. So what I'm trying to explain is that we learn every day by detail, but at the very end, the application of what we learn to the patient is extremely simple. And I think that's basically what is happening. And I can give you an example. The ischemia study. Everybody talks about the ischemia study. Everybody talks about the ischemia study. And you know why everybody talks about the ischemia study? Because it says you may avoid procedures on anybody, even if you have severe angina or stress testing. That's what people are doing very simplistically, very, very simplistically. But this is just an extreme. Why? Because in the angina or in the ischemia trial, you actually exclude so many patients that at the very end, you end up thinking simplistically, but in this case, you actually evolve with no left main disease, not severe angina, no left ventricular dysfunction, no XYZ. So you end up very simplistically, but look, all the rest goes away, but we think simplistically. What I'm trying to say is at the very end, right or wrong, we do simplistic things. What happened with ischemia, now people realize that we are excluding so many patients that the quote of this ischemia trial will be less and less as we move more and more in patients with complex disease. So, but we tend to use simplistic approaches. So I'm trying to answer your question. Yes, different types of plaques may be important in understanding. We are doing this in the progression of disease with MRI and PET, but at the very end, the approach to the patient will not be by the quality of plaque and all of that. I tend to doubt it.
Thank you
The
very
burden
much.
of disease is the important thing.
Thank you very
Again,
much.
I'm expressing to you guys my opinion, of course.
We have one other question from one of our fellows, Fami, that I believe she's not logged in, but she gave us a question. Her question was, so the ACC/AHA guidelines recommend the screening for subclinical atherosclerosis in a select group as well, when we have age after 40, borderline to intermediate risk, and the LDL 70 to 190. Her question was more, we're excluding these patients at the very high risk LDL over 190 or the ones that have control LDL already? Should we be excluding them or not?
First of all, let me tell you something. Guidelines are always late. So when we talk about guidelines, you're talking already something that maybe is of interest, but certainly is not how the medicine is working. The problem with guidelines is start at age 40. And you miss completely the most important risk factor for coronary artery disease is in between age 10 and age 40. I can tell you that. And this is what we are finding in all of our studies when we address subclinical disease. And we found that the burden of disease at this younger age has a tremendous impact of what happens afterwards. So I think that going back to the question, let's just do subclinical, look at those who are high risk and so forth. Maybe at this time, I don't know how you define these people anyway, but I think what is really happening is the following. As editor of JACC, I called the guys who wrote the guidelines about a year ago. And Dr. Grandi, I said, look, my friend, you are dealing over age of 40, and we are finding is all under age of 40. So better you write an article for JACC and explain that you guys are out of line. The article was written just 3 weeks ago, 4 weeks ago, state of the art. And that is related to the younger population. And they talk about young adults and they quote all of our work and they go, it's a movement. So what I'm really trying to say is at this moment, we should do a screen this and that. I don't know who I would screen, but I will tell you what's going to happen. At age 20, you are going to start screening people regardless. And then you will begin to develop the disease for factors that maybe you don't understand today. Other risk factors may be present. So it's right to follow guidelines. To me, at this moment, if I be frank with you, with all the guidelines in the world, I use common sense still when I see a patient. Very rarely I go to the books and see what the guideline says for this, and that. It's nice when you present a patient in your rounds that you have to quantify or go there and see what the guidelines say, the green and the red and the whatever yellow, that's fine. But in real life, with all my experience in dealing with guidelines and no guidelines, I still think in front of the patient. And very rarely I go to what the guideline says. I am not trying to tell you not to go to guidelines. What I'm trying to tell you, the guidelines is a guideline, and the best guideline after a long term of experience to me is the intuitive feeling that you have based on your experience. That's all what I can say.
So Valentin, do you think that when we do an imaging is similar to what we look at the stars with the Hubble telescope? We look at events that happened hundreds of thousands of years ago, and we see them now, but they already existed, and that's the same that happens with imaging.
It's a good similarity.
Yeah,
I agree with you.
so at 20 years old, imaging is not the way to screen.
No, let me tell you what happened, because we have the data already. We are beginning to see disease already at age 20. And actually, this disease at age 20 progresses. Actually, we have the data. We have published that. No, we have published data from age 40, but we have seen this, you know, where in the family study of Harlem. There were 600 patients in Harlem, excuse me, not patients. These were children, age 5 to 6. And part of the study in Harlem was to screen the parents. And the parents were between age 20 and age 30, age 35. And we did all the technology that I presented in the presentation the other way. And the paper is coming out very soon. I think has been, yeah, it actually has been accepted, in which we already see disease at that stage. And let me tell you one thing, the disease progresses, and then you may say, I don't think progression of the disease, you may be skeptical and say, progression of the disease means nothing, not necessarily means events. Events come from another. Well, I can challenge you by saying that in the bioimage study, we found that as the disease progresses, certainly in the 50s and 60s, that age leads to events. There's no question about it. Why I have to reject the possibility that a 20-year-old in which we begin the disease to be identified and projects and progresses, how can I say this has nothing to do with events that happen later? We cannot say that. So my point to you is the concept that you presented with the telescope, I think is a good concept, but I still will go at age 20, because I think what you see there is trouble. And particularly if what you see there 3 years later, you see is progressing. And this is what we have found in later age. So answering the questions, few of the questions already presented, I think risk factors are important. They were not taken into account between age 0 and age 40 in the guidelines. They were taken into account later. And imaging is important at young age, and that's where I see the future.
Thank you very much. We have a question from Dr. Yang, one of our fellows. I believe she's not there also. The question comes on the cost analysis and insurance approval of imaging for screening. How do we get the insurance to approve it, or is it the cost analysis, is cheaper to do it?
Bad news, bad news, bad news. I am now with Medicare fighting the calcification of the coronary arteries be approved. And I have been working for 3 years on that, and we are not going anywhere. And that is today what's happening with Medicare. I'm talking Medicare like any other organization, is they want to hear hot stuff that is really hot. And to go into prevention, to go into subclinical, to go into that, they don't listen, because they feel that the events are speaking by themselves. So here's a situation that I think we are going to have trouble in terms of reimbursement. However, if you're asking my opinion on what is going to happen in the next 10 to 20 years, it will be completely the opposite. The reimbursement will be not only to identify disease early, but will be better reimbursed those people who dedicate their lives to that than the interventionists. I can predict to you. Today, interventionists get the money. Those of us who are in risk factor profile and prevention don't get the money. What is going to happen in the future, I can predict to you, is going to be the opposite. And the same is going to be how we'll identify. We will identify people much earlier. How do I say this is going to happen? Well, I can tell you the funding at NIH. The funding in NHLBI about 10 years ago, 80% of the funding was with events, cardiovascular funding, events, procedure with events. Today, 35% is already in the preventive mode. So research predicts what is going to be happening with organizations and reimbursement in the future. And this is basically what is happening. So I think you guys are young, and this is why I'm having this discussion, by the way, because I want to discuss what I think is going to happen when you are really in full practice. And in full practice, I can tell you reimbursement is going to be quite different. So those of you who say, you know, I want to go into intervention because I love it and I love it and I love it, and I will be able to buy a good car and to have good vacation. I can tell you that. The future is going to be different. And the reimbursement is going to be different. And that is because people are now learning that the cheapest medicine is the one that you prevent. But the organizations today are still in the hot stuff. And research is telling you where is the movement.
Thank you very much. Very good point. Jennifer, you have a question?
Again, I am expressing personal views. Very, very important, because many of you may have a different point of view. And that's the reality, but this is my view.
Thank you, Dr. Slivchuk. Actually, one of my co-fellows, Roberto, actually had a follow-up question, so I'll let him go ahead.
Hi, good morning, Dr. Fuster. Thank you for answering our questions. My question is following a similar line of thought than the answer you just provided to insurance coverage here in America. Given all your international work and your global work, to say the least, how do you think that the findings of imaginomics can be incorporated into healthcare policy in medium to low income countries, especially seeing that they are already past the epidemiological transition from acute illnesses causing death to chronic illnesses causing death? How do you think that can be done in these countries?
Well, let me go back. First of all, this country is very young. Let's not to forget, this is not Europe, all right, where universal health is almost in every country in terms of reimbursement and so forth. Now, I suggest you to go to a paper written in Lancet in the last 2 years, and is a commission by the Financial Times and the Lancet. They put 25 people together and looking at what is the future of artificial intelligence. That's irrelevant. What is relevant is they talk about that one of the first issues that should be solved is not artificial intelligence, but is care to be affordable for everybody. That's basically how they start. And they got a number of people, they talk about artificial intelligence, and actually one of the aspects being touched is exactly the one you mentioned. And from the very beginning, they say this has to be solved. Otherwise, we are going to commit suicide here. And they talk about the United States, and they say how United States should move towards universal coverage compared with other countries. And there is no criticism to anybody. This is a young country. And it's a country of survivorship. Remember, people who came to this country, they developed themselves very individually because they wanted to have a possibility of surviving. So this is a country that has been individualized from the very beginning in history. And now we are beginning to understand that if we don't work together, things will not work. But this is timing. In that article, it says how United States will be moving in the next 10, 20 years towards what you are talking about. And it's very fascinating. So I don't want to go into the details, but I think it's something you should read because it's a very important paper by a commission that actually interviewed many people. And among the things that come out from that paper, very interesting, very, very interesting. And that is the future is of the young people. these are the people that will manage the world. Better knowledge, artificial intelligence will be very a significant part of them. And the other aspect they mentioned is that these young people will drive the way, but they have to be educated when they are aged 5 to 6 to 10 years, which is what we are doing at the present time, as you know. So I am just giving you a pattern of the future to solve all the social issues that we are dealing with and disparities and so forth. It starts from education at a very young age. And then this will move these young people, very well educated, when they are in their 20s, their 30s, and their 40s, will be the drivers of the world, will be a different world. I'm very positive and optimistic in a moment that the world appears to be in chaos. And there is something else I want to talk about the subject that we are addressing with. I recommend you to read the book of Eric Smith and Henry Kissinger, which just is called Artificial Intelligence, just was published. And they are beginning to predict how the world is going to move politically in the next 10 to 20 years. And basically, this is the dilemma. Artificial intelligence will be able to tell how to avoid war and how to move, avoiding collision and these dramas that you see today, based on all what artificial intelligence can collect from history. But this has another aspect, and it's the aspect of power. And that is, what is going to be the choice by governments? Power or artificial intelligence? Do you understand it? And what I'm really trying to present to you now is that all these issues that we are talking about, disparities, wars, and drama in the world, artificial intelligence will be able to tell us how to move to avoid all of this and to solve all of this. But in the other side of the equation is the ambition and the power of the people. And that is going to be a complete crash. And what this document comes out with, the young people who are very well educated are those who probably may move the world into the right direction. I'm just giving you a summary of a talk I gave to the American College 5 days ago, which was one of these lecturers of the college. And the lecture was actually health, technology, and humanism. And if you wish, and you invite me again in the future, I will give you this talk, because basically it's the crash that we have today between these three aspects. And the question is how we solve that. Well, anyway, look, I am not pontificating. I am here to talk to you in the way I think, which is very personal and maybe right or wrong, but I think that's what the discussion is about. I hope I answer your question about what you have in a much more global way. And I wouldn't be pessimistic. This is a young country. And I think we are going to move forward.
Thank you very much.
So can I go in the same direction with another difficult question here? So another news that has resonated to me in the last few weeks is the fact that life expectancy in the US fell by about 2 years compared to pre-COVID. And we are now 5 years behind the average in the European countries. Even though we had the technology and implemented vaccination early on, we seem to are behind. Is that a problem of the healthcare system? And I'm interested in hearing your opinion on this.
Well, first of all, I think there are two aspects in your question that I think have to be very separated. One, I know the answer, the other I don't. Or one, I think I know the answer, and the other I know. One thing that is happening at this moment, when you look at the curves of survivorship in the United States, is reaching a plateau and mortality is beginning to increase. This is a reality. And The question has to do with obesity, diabetes, and the metabolic syndrome. You know, I was just doing a podcast for Chuck yesterday, and it was amazing to me. And the first article in a couple of weeks is about bariatric surgery. Do you know in this country that in the adult population, it is expected in 10 years that 41% of the people will be obese if the whole trend continues? So this is the answer to the first question, and that is, we have a problem. And the problem is we have to really try to see how we overcome metabolic disease. And in a world of consumption with the stress and so forth, people eat more, eat the wrong things. The cheapest things are those who make you fat. And it's a reality of the world we live in. This is really a problem, a big problem. Now, the second question is about COVID. And that is what happened between United States and Europe in terms of COVID. I don't have the answer to this. And I will tell you more about it. I don't know the data, how accurate all this data is. Why is that? Let me tell you why I feel skeptical. We are running a trial, which the results will be soon out. It's about COVID. And this is the largest trial on anticoagulant therapy. Our trial has already entered 3,400 people with COVID in the hospital, treated with 3 different anticoagulant arms. And I have been in contact with the world constantly for one reason. It's an international trial with 100 institutions around the world participating on. And let me tell you, one of the main issues has been to collect data. And I have gone data to the governments, trying to collect data for us. I mean, what are the patients that should enter into the study and all of that? And you know one thing, I cannot trust anything. The data that came to us is so discrepant, so nonsense, that changes from day to day. And I don't know who is getting the data and how the data is percolated to the public. So in answering your second question, I don't have the answer, but I don't have the answer because I don't trust the data to start with. And this is basically has been my experience in dealing with this study. It's amazing. Every day is a different data. And you can talk, and we talk to governments, we talk to ministers of health, because they were very interested on the study. So anyway, this is basically the answer that I can give to you. We are in very bad shape in the United States with the metabolic syndrome. About COVID, I'm not sure how to compare with other countries.
Thank you very much. And I know we said 45 minutes, so we only have a few more. I know the fellows have some questions about career advice. You gave them some career advice, but I guess turn into what would be career advice for the fellows, early career attendings, mid-career attendings, or late? How do you see these transitions?
Okay. Any question?
So what advice would you give for the fellows in the changing world?
Well,
there?
You know, I don't know. I want to have a specific questions. I can only say to you, okay, if this is the question, is a general question, I would tell you what I tell the fellows the first day that they show up here in a fellowship program. And I say, look, guys, this is the beginning of your life. And when you finish, it's not the end of your life, because life progresses. So when you look at your future, remember, every day is a new day. It's not the day that you graduate in your fellowship is going to be the end. In fact, it's not. Things continue to move the same way. So every day is important in the long-term follow-up of a fellow today. Having said that, there are 3 issues that I emphasize. The first issue to me is critical, and that is you fellows today are the cream of the world. You criticize everybody, but the fact of the matter is only 1 in 1,000 people have reached the stage that you are. And I look at this figure originally, and I don't think it has changed much. So you are 1 of 1,000 who is lucky to be where you are. please don't forget what I'm saying. And that is, stop criticizing, stop always saying negative things about everything, because you are the game. So you are obliged to give rather than receive. That's my first message to you. You are obliged not to criticize, but to create and to do something that is actually meaningful. This is for society. This is my advice number one. Now comes advice number two. The advice number two, to me, is probably the main problem that we face with fellows at your stage. And that is, what really is your talent? Have you discovered it? Your ambition is a different story. It has nothing to do with talent. In general, actually, ambition is trying to reach something you don't have. That's my best definition of ambition. So it's better you guys cool down and find out who you are. Here is where mentorship is critical. And that is people who know you, whether it's your family or whether it's somebody in your business, whatever it is. But people who know you will tell you, know, I think you're very good on this, and I think you're very good on that. Maybe you will not be so good on this. Maybe you will not be so good on that. This has nothing to do with ambition. It's actually the opposite. And the best investment you will make in your life will be to do what you are good at. I don't have any question about it. I can give you my own example. I have positions that were offered to me on various levels, and I always said no, because what I do the best, my field, is exactly what I'm doing this morning. That's where I feel myself, dealing with people, with young people, and talking with that. That's what I feel. So therefore, I'm not going to go to a big position of a dean of a university, which I will be there in an office there, and I will probably don't last more than 2 years. So you have to know what is your talent and use it properly. And nothing better than actually mentors. Within that context of your talent, remember, you have to be creative. And I told you the item number one, give to the world. And to be creative is not writing papers myself. This is part of creativity, research. But there are many other paths you can be creative without having to rush to be pressed to write papers. You can be creative in education. You can be creative in creating a new section or something new, or whatever it is. But be creative and use your talent. If your talent has been well identified, just go there and get away from your ambition of doing something else that perhaps you don't have the tools. And number three is to work as a team. In the past, you know, Dr. Mario Garcia and myself, you know, we were a lot of self-made, frankly. It was a different story. Today, society, forget about you as an individual. I have to tell you, you have to accept it. You are part of a team. And if you are not prone to work with a team, but just to go with yourself, you will crash. Society will not accept you. I can tell you that. So these are the three principles. First, give to society. Second, see who you are. Be sure that you follow that is the best investment. And within that context, be creative. And creative is not only writing papers. And the third issue is you are part of a team, my friends. You know now, you are part of a group, and you have to behave as part of a group, not as an individual. So these are my three messages I would give to you as a general question about the future of you as a fellow. And remember one thing, the best happiness, if you believe on that, is when you do what you are supposed to do. That's where happiness comes. Family and otherwise, you are doing what you are supposed to do. And the best investment is use your talent and do the right thing. Then you will be much more pleased with yourself than a neurotic wreck when ambitious really drives people crazy in trying to reach things that they cannot. And then you are neurotic every minute of the day. So these are my three main advices I could give to you.
That's amazing. Thank you very much. I think that's what we were looking for. Dr. Garcia, do you have any further questions? Otherwise,
I just wanted to say thank you for for being so inspiring. I know you now for a couple of years. In my career, at many points in time, you have been inspiring, and you continue to be. So I want to thank you on behalf of our fellows for doing this.
Thank you. A final comment is about Mario Garcia. I knew Mario Garcia much earlier than when he joined Mount Sinai, actually. And I will tell you, he's one of the nicest and more honest people you will ever meet in life. So I think you should take advantage of that, and very talented. So I only say to you, I say this because it's important. Who are you dealing in your place? And I don't know all the other people at Montefiore. Actually, I don't know. I know people, but I don't. But I know him though. So take advantage, because he's a role model for you. And this is all what I can say.
Thank you.
Okay, guys.
thank you very much for the time.
Until next time. Nice to all of you. Invite me in a year from now. I will come back to talk about something else.
In person. In person.
Bye-bye.
Bye-bye.
Bye-bye. Thank you.